Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Hello, and welcome to Conversations with CEI. My name is Dr. Erica Bostick, and I'm an adolescent medicine physician at the University of Rochester and faculty at CEI. I'm thrilled to be joined by my colleague, Dr. Uri Belkind, to talk about updated guidelines by the AIDS Institute on adolescent consent to HIV and STI treatment and prevention. Dr. Belkind is a board-certified pediatrician and adolescent medicine specialist, as well as an American Academy of HIV specialist. He works at Callen-Lorde Community Health Center in New York City, where he serves as the Associate Medical Director for Adolescent Medicine. He also is the Clinical Director of Health Outreach to Teens, or HOTT, which is a comprehensive multidisciplinary program designed specifically to meet the medical and mental health needs of LGBTQ adolescents and young adults ages 13 through 24. Welcome, Dr. Belkind, and thank you for joining us today.
Hi, thank you for having me. It's really nice to be here today.
I was so thrilled to see official guidelines put out here because this comes up, at least in my day-to-day, pretty on the regular. There's so many questions that come up related to adolescents in general. And as you mentioned in the guidelines, many adolescents in New York State self-report being sexually active. And we have lots of data to support that nationally as well. And we also know that adolescents are disproportionately affected by STIs. So I'd love to know more about how this comes up on your day-to-day work as an adolescent medicine physician.
I work at an FQHC that mainly sees LGBT population. We do a lot of sexual care, a lot of reproductive health. We see all of these young people that are coming either with symptoms or just for screening for STIs. And for a long time, all we could do was screen them and test them and treat them. And we were allowed by law to do that without involving their parents. And then a few years ago, New York did a really good thing and changed their guidance. So one of the first things that happened is that minors were allowed to consent for their HPV vaccine. And so that was the first time in New York State. And part of why this is challenging is because the laws are different in different states, right? Like some things are the same, but every state has different laws when it comes to minor and adolescent consent and confidentiality. But at that point, minors were allowed to consent for HPV vaccine, which was the first opportunity for them to actually consent to prevention of an STI. We were putting the cart before the horse. We were able to test them and treat them, but there was no way to help them prevent it. Based on that, we started talking about HIV. HIV used to fall in a different category in terms of the laws than STIs. And part of that had to do with confidentiality and more stigma and all of those things. Like some of those things made sense, but it also tied our hands a little bit. We had adolescents that came in that were diagnosed with HIV. We needed to include their legal guardian or their parent in order to treat them. That created a set of issues. And then HIV prevention was also an issue, right? If we wanted to give post-exposure prophylaxis or PEP to an adolescent, again, we needed consent from a parent. And the timing of that is pretty important. Any delay could actually have adverse outcomes. And then as PrEP, pre-exposure prophylaxis, came into the landscape, minors, again, they were able to access it, but with parental consent. And as adolescent medicine people know, and anybody that deals with adolescents, not all adolescents can or are willing to or are able to have those conversations with their parents. And I do want to say, parents are welcome to have these conversations. We don't want to sideline parents. We want parents. We want responsible adults. We want legal guardians that can support adolescents in making these decisions. But we know that sometimes either they really are not available or that type of disclosure from the part of the adolescent could really put them at risk of rejection or even violence. We've recognized the importance of providing confidential services to adolescents for over 30 years. We've had a lot of experience doing this, and I think we all agree that it's great when we have supportive parents, but the alternative is to not seek services when they're needed. So these laws actually allow us to really serve our patients the best way possible.
You're spot on there. So much of adolescent medicine, and really medicine in its essence, is grounded in prevention. We're trained to deal with the illness or intervene for the situation that needs surgery or medicines or whatever. But in the ideal situation, we should really be focusing our efforts on prevention. And so you said it so nicely in the guidelines. This guidance does not intend to minimize the role of supportive parents, guardians, or other adults who may provide additional support to help adolescent patients adhere to their treatment plans. But as you said, it's just not always possible. When you say this is confidential to the young person, you have the right to consent to this, and you ask them, is there anyone else that can be part of this with you? How do you navigate those conversations with both the patient, kind of encouraging them if there's any way to involve a trusted adult, and or with the trusted adult who may not be able to, through no fault of their own, potentially, not be able to be part of this conversation?
I think we need to weigh both sides. Is there someone that can help you, but also would disclosing actually potentially lead to harm, right? Again, whether it's becoming homeless or being kicked out or even violence or abuse, etc. So I think it is important to help the adolescent think about what would happen if they were to disclose, whether it's an unintended pregnancy, whether it's an STI, whether it's certainly HIV. It is important to help the adolescent find someone that could be supportive, explain why it would be important to have someone that's supportive, right? And if you're treating, I don't know, like a bacterial STI, you give a dose of antibiotics, that's it, that's done. Maybe not as important, although still, but could be traumatic. And so there is a role for that type of support. But in issues where we're using medications chronically, whether it's birth control or PrEP, then there are a few other things that come into play, right? First of all, it can be hard to take a medication, to maintain adherence to medications that you're taking chronically. Our health system is complicated, right? You need to sometimes deal with insurances or prior authorizations or even refills at the pharmacy. And when you're young and have never had that experience, it can be a little bit challenging. And then the other thing is, if you're taking a medication chronically, you have the bottle or the packet or whatever lying around. And so there's a bigger chance that if you're at home, somebody can find it. Including an adult just takes care of all of those things. So if it's possible, it really just lowers the temperature in the room so much for everyone involved. It may be that adolescents might not always feel like they will be supported or feel like the reaction is going to be really negative. And oftentimes that's not the case. And for parents, again, parents that want to be part of this conversation and the adolescent doesn't let us, well, again, we can talk to the adolescent, but they have a legal right to confidentiality. It's not that we want to exclude the parent. We can talk to the adolescent and, hey, listen, your parent seems to be really supportive. Would you want to have this conversation? But in the end, if the minor is consenting for this type of care, then it's their right. It's just as any adult. So we have to weigh all of those things when we work with adolescents, ensure optimal health outcomes, prevent accidental disclosures, try to incorporate supportive systems or networks, and making sure that they remain safe.
You brought up two things that I think are so important and so complicated. One has to do with the systems issues that New York, I think, is ahead of the game in terms of really recognizing the importance of adolescent confidentiality for lots of things. But the system often lags with operationalizing this. And whenever I give a talk, and probably when you give talks on this, there is inevitably a question about what do you do for the explanation of benefits or the EOBs, or what can my clinical space do to try and support the legal right of confidentiality for this young person when there are so many stops along the way that could accidentally disclose whatever confidential information is being transmitted. And the stakes can be so high. There is no way to ensure a perfectly confidential system. Does your clinical space have any workarounds or things that you've operationalized that maybe our listeners could benefit from learning from?
Our institution is very supportive of the work that we do with adolescents. And I think that's really important. And it's something that's happened through many years of advocacy of our own on behalf of our patients within our institution. So our practice is there's like a real danger of an adverse outcome due to accidental disclosure, we cover the cost of the visit. We're lucky that we have a 340B pharmacy and we can give the medication without cost. So we don't even document the insurance part. And I realize that this is utopic, right? I know that not a lot of people would be in a similar situation. When talking about commercial insurance, there's the issue of the explanation of benefits, which has a reason of being, right? It's to prevent fraud that unfortunately does happen. But when it comes to minors, the policyholder will get this letter in the mail that says, hey, you used this service. If it's Medicaid, like Medicaid will not send explanation of benefits. But if it's a medication that needs a prior authorization, then they will send a letter because it's a prior authorization, right? So that's more dealing with the pharmacy side of it. Multiple areas where we have to pay attention to. And that's one of the things that those of us that love working with adolescents, we're, okay, sure, we'll figure out that puzzle, but it is time consuming. It is labor intensive. It takes a village.
And I think there's a lot of push in the ideal world also. We would have just a bigger village. We would have people with different skill sets bring all sort of knowledge and skills to the table. And I think if you do have a clinical space and clinical team that really follows that and models that, I think when we go to conferences or when we see each other and our colleagues in various places sharing this information, what's worked well for your clinic, I think that's key because reinventing the wheel is also time consuming and labor intensive. And that's particularly why I love touching base with colleagues because this is a generalizable problem.
And there's instances where the only option is to actually refer your patient somewhere else, right? There are places that are really good at using family planning benefit program. But in those cases, again, it doesn't go through insurance. It's time consuming. You need someone that knows how to do it. And your billing department needs to know how to bill for those visits. It's always a little bit more complicated than it can be. So yeah, we have had to refer patients, right, to other places that can provide those services for free.
That's an important point because it doesn't mean you are doing anything wrong. In fact, you're doing the right thing here because the risk can be really high, like you mentioned, for a subset of patients where the stakes are just too high to risk it. And I think part of my general counseling and probably our general counseling and might be a good idea to have our listeners consider is really stating quite frankly to the adolescent that we will try our best to keep this private. You have a legal right to this privacy, but the system is imperfect. So what would it mean should somehow this information get to your parent or guardian and having a conversation about that, like you mentioned in the beginning. The other thing that you touched upon, and I think often comes up too, is other healthcare providers. We know the laws, we do this every day, but some general practitioners who also serve adolescents may not. Are there any resources that you recommend for more general providers who want to do the right thing here, but are just confused on how to do it?
The one resource that I love is the New York Civil Liberties Union. They have a booklet. It's also available online. That's called Teenagers, Healthcare, and the Law. What happens if a minor goes to the emergency room? What happens if a minor is seen in a school clinic? What happens if a minor wants to be seen for substance use treatment or for mental health or behavioral health treatment? And certainly all the aspects around sexual and reproductive health, right? Whether it's accessing abortion or contraception or prenatal care or sexually transmitted infections.
And I think the other thing that comes up sometimes is the person who feels moral distress related to providing this care in confidence. And that's very real too. And I think we need to acknowledge that because most of us go into medicine to really serve, but it can be distressing at times. The situation that you gave an example of earlier of a parent who seems very supportive, really wants to be involved, but the teen they're not open to it for whatever the reason. That may not feel great for the healthcare provider. Perhaps they're a parent too. Perhaps there's some transference, countertransference going on. So I think it's also important to recognize that might be happening for some of our colleagues. At the same time, similar to other situations, if you, for whatever reason, can't provide the care that is needed, then it is your obligation to refer that person to somewhere else.
Back when the birth control pill first came into being, and so then everybody's going to have unprotected sex. And then with the HPV vaccine, some parents did not want to give the HPV vaccine to their daughters when it was first approved. because then they're not going to use protection. Now they're going to become sexually active because now they're protected. And when PrEP came out, it's, so then people are going to stop using condoms. And there's been studies done that in general, that doesn't happen. One of my favorite studies, like from 2002, that they asked young women that were going for family planning services, okay, if the law were to change and for you to receive services here, we'd have to tell your parents what would happen. And 60% said, I would just stop coming. And others were like, I would only come if I really had to. And when they asked, would you change your behaviors? Some people said, like, I would use more condoms. Some others were like, what I would do withdrawal method. Only 1% said I would stop having sex. Just like providing the service does not increase a behavior, removing the confidentiality does not stop the behavior.
Amazingly incredible and important point, because there are, like you said, there are so many studies on this and so many professional organizations, the Society for Adolescent Health and Medicine, the American Academy of Pediatrics, so many have position statements out there about the importance of adolescent confidentiality backed by all these studies. And yet still, even the most academic person still feels in their gut that, if I talk about this or I promote this or I offer this, then am I increasing risky behavior or am I increasing sexual activity? Back to the statistic that's in the guideline about 40% of high school students reporting that they've engaged in sexual intercourse by 12th grade from the YRBS, the CDC. Adolescents are having sex. Adults are having sex. Sexual activity is just a developmental part of life. And so by trying to ignore that fact in itself is being obstructive, let alone removing or adding barriers to accessing information that can help young people make healthy decisions for themselves. And this crippling fear that some parents, providers, guardians feel by just saying the words is going to promote or not promote something, I think is a myth that needs to be debunked right now on this podcast.
Adolescents can make healthy decisions for themselves, and they often do. They're able to understand when they come for a treatment, they're able to understand the consequences of receiving treatment and of not receiving treatment or adopting some kind of preventive strategy or not. Minors really can consent to that. And yes, minors might not make the best decisions all the time. And part of it is development, part of it is just lack of experience. But the fact is we shine a light on the times that adolescents make wrong decisions, and they're adults making wrong decisions all the time and nobody says anything.
So true. So many people that I speak to when say, I'm an adolescent medicine physician, usually there's, how do you do that every day? Oh my gosh. And then some people are like, wow, that's so cool. What does that even mean? And so I think teenagers are just so marginalized in so many ways and underestimated. Their strengths are there. And often, like you said, the light is not shined on those. One takeaway that I would like to make is just that adolescents are in this amazing stage of life where they're at this fork in the road. And by creating facilitators to healthy decisions, including sexual health, is only going to be beneficial. We've got anecdotal experience that tells us that. We've got really solid science and evidence-based medicine that supports that. Yet teens still can be marginalized in a lot of ways.
When we're talking about HIV, there's stigma in HIV. And then, yes, community most affected, specifically in youth. It's young men that have sex with men. And so that's an extra layer of stigma. It does create all of these issues. We know that LGBTQ youth, for example, are more likely to be homeless or to run away from their home or to be kicked out of their homes. There's even less access to a supportive adult in those instances. New York in 2022, 2023 actually passed a law that now allows all homeless and runaway youth to consent for all aspects of their care. That's a step forward, but again, it's like also an exception. How do I know if they're really homeless? How do I know if they're runaway? What does that mean? There's letters that come out and there's FAQs that are out from the Department of Health, but it creates another layer of concern.
At the same time, we need to think creatively. Nobody goes into adolescent medicine or into a field of medicine that serves adolescent patients because it's simple and straightforward, right? We need to work together to really think creatively with policymakers, with key stakeholders of how can we best serve our youth in this really unique preventative, spirited time in their existence so they can really grow up to be the healthy adults that everybody agrees or should agree that they deserve to be.
And a plug for adolescent medicine, right? It's awesome. And you need to be creative, and you need to find different ways to do things, and you need to be open to do them. And then I couldn't be happier with my choice of field.
Wrapping up, thank you for such rich, complicated, yet simple at the same time conversation related to adolescent confidentiality and how we can best serve adolescents in a comprehensive, sex-positive way. What are the biggest takeaways that you want listeners to walk away from listening to this podcast?
I think, again, the most important thing is that adolescents can make healthy decisions about their life. That's the first one. The second one is that there's not always a supportive adult, or the adolescent might not always feel that there's a supportive adult. And we can sometimes help them find that adult. Sometimes we can't. But that doesn't mean that they should not be able to access services that are well proven to benefit both them and even as a public health measure, right? If we're talking about HIV, undetectable equals untransmittable, it's a public health issue, and same thing with STIs, et cetera. I think it's important for us to know what the laws are where we are practicing, and it's important to advocate for our young patients, right? Like oftentimes there's no policies in our institutions that tell us how to deal with that. That's where we need to put our thinking hats on and say, okay, so let's create this policy, or let's figure out how we get around this, whether it's with electronic health records and patient portals, or billing, or how to schedule appointments, or all of those million moving pieces. But it can be done, right? There's great examples of places where it's being done.
Thank you so much. We'll be sure to include resources that we discussed in the description of this podcast. And thank you, Dr. Belkind, for your time and expertise.
Thank you so much, Erica. It's my pleasure.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.